What's the difference between a jeweler and a cell biologist? No guesses? A jeweler and a cell biologist. One sells watches, and the other one watches cells. What kind of animal would you never play video games with?
A cheetah.
A cheetah, very good. Who earns a living driving people away? Taxi driver. Or you can say Uber or Lyft, right? All right. Very good. All right. So how is everybody? Let's check our schedule real quick. So today's the 24th. We're talking about tissue repair, fibrosis, and healing in today's lecture. And then if you guys take a peek at your syllabus, you'll notice that next week I'm out of town. So you still have all the same requirements that we normally have. So Monday we've got a pre-quiz by noon, and Friday we have a post-quiz by 11:59 p.m. And then the lecture is already on YouTube. Okay, so it's, how many of you have been to the YouTube site, the YouTube website to watch the lectures? Okay, so those of you that have not, if you go to the front page of the syllabus, there's underneath the text, it says online 80 lectures, and there's a link, there's a YouTube website link. And that should take you straight to the pathology folder for my YouTube page. And all of the lectures from last year are still there, last fall. And then the lectures that we had this year, where I clearly look a year older, those are the newer lectures. So next year is going to be a little bit of a pump fake, because you're going to see me a year younger, okay, on the YouTube. And we're just going to use last year's YouTube lectures. You guys with me? Okay. So that content's already there. That's how we're going to handle next week. That's also how we will handle any act of God. If I get sick or I'm unable to show up to class, we will just have you go to YouTube like we are next week, okay? Hopefully that'll never happen. But if it does, we've got this archive, and we'll go from there. If you look at the schedule the week after next, so 2 weeks from today, what happens? Our first exam. Okay, our first exam. Good news is that week you don't have any pre-quizzes, you don't have any post-quizzes, you just have the exam, that's it. Some of you ask, are we having lecture after the exam's over? Because it's like a 2-hour class period, and the exam will probably take you, I'm guessing, about an hour. But I think that's cruel and unusual punishment to give an exam, and then you make you listen to me on the new content. Okay, so we're not going to do that. What's that? We do have to wait for the last person to finish, because that would be rude. I would agree. Yep. All right. Any questions on the schedule or what's coming up? Okay. SI session this afternoon, right after class. Taryn and I are working on kind of a cool resource document for you guys. So I don't know when she's going to unveil that, but I won't steal her thunder, so it's coming. Stay tuned, okay? All right. So today we're talking about tissue repair, fibrosis, and healing, and I want to kick off our conversation with this chart that I showed you last week, okay? At the very end of last week's lecture, we kind of compared and contrasted acute versus chronic inflammation, and we showed this chart as a example, or a component of this chart as an example. So I wanted to go back to this. This comes out of an old text. Like every single one of my grad students has actually read this text. It's sort of an unspoken requirement. Okay. This is the text that I used in grad school. So this is actually a 1986 publication. And yes, I was in grad school in 96. Did I say 86? Wow. I'm not that old. 96. Okay. So I was in grad school in the 90s, and this characterizes normal wound healing. And you can see in normal wound healing the first two peaks, which are early and late phase inflammation. And what do you think the early phase is characterized? What cell types are in the early phase of inflammation? Neutrophils, very good. They're the first responders. The second phase, or the late phase of inflammation, what cell types do you think migrate there? What's that? I heard monocytes, I heard macrophages, so you're both correct. They're really called monocytes when they're in the bloodstream. As soon as they leave, right, they extravasate, they're called tissue macrophages, or activated tissue macrophages. Okay, so just understand that nomenclature. Don't get misled on an exam. I probably won't try to trick you and put monocytes and macrophages and be like, right? So, but just understand that there is sort of a very unique difference between a circulating monocyte and a tissue macrophage. But you're right. This is characterized by these macrophages that move into the tissue. And then we see granulation tissue formation. You're going to see histology of these phases today. That granulation tissue is named because of the way it appears. It looks granular. There's a lot of inflammatory cells that are in the area now, and they release a lot of these angiogenic growth factors and cytokines, and they stimulate new blood vessel development. And that starts to recruit new cells to come in, known as fibroblasts, into the tissue. And you have fibroblasts in every cell, or every tissue type in the body, not just in skin, but a lot of today is going to be talking about skin fibroblasts. Once the fibroblasts move in during this granulation phase, and they take residence, they're going to proliferate, they're going to migrate, they're going to move in, they're going to lay down matrix, collagen matrix, which is the reparative process. And this collagen accumulation happens, and this moves on and on and on. And wound healing lasts about how long? We talked about this last week. About a year. It's about a 300 to a 360-day process, so about a year of time that a tissue has completed its remodeling. So if you have a wound, a skin laceration or injury, and you've noticed months after it's closed, it's still kind of pink in color, right? Or it doesn't look quite completely healed. It takes almost a full year for it to completely turn over and remodel. Okay? So, I want you guys to talk amongst yourselves so I can get a little bit more organized, but also so that you can characterize the difference between resolution and repair. Okay, so tackle the first conversation piece. What is the big difference between resolution and repair? We've been talking about wound healing, okay, but now we're going to dive into two very specific categories within wound healing. So resolution, or wound repair, as sort of subtopics of wound healing. Does that make sense? All right. on the second one. The difference between healing by first intention versus second intention. Okay? I'm going to blow my nose. Okay, folks. What do you guys got? Who can compare and contrast wound resolution versus wound repair?
So wound resolution is the kind of the formation of the regeneration of cells. It usually ends up in 100% functionality afterwards, while repair leaves scarring tissue and functionality might not be there afterwards.
Did you guys all hear that? That was actually spot on. I'm going to try to repeat it, but correct me if I butcher it. That was really well done. So wound resolution typically means that there's this repopulation of cells into the tissue. And those cells return or rescue function. We shoot for 100% return or restoration of function. Wound repair is referring to the fact that the hole or the gap is probably closed, but there may not be the recruitment of cell types that restore function 100%. And more classically, with repair, is you see fibrotic scarring or fibrosis. Okay? So one of the better examples that I like to use is if you hang a picture on the wall and you have to put like drywall anchors so it leaves a big hole when you pull out the picture you move out, you can put spackle and patch the hole, right? But if it's big, it may not match the texture of the wall, it doesn't look quite the same. You can kind of tell where that repair was made. Okay? Resolution would be like you actually just re-drywall the whole wall and then retexture it and then paint it. Okay? So, big differences. Question?
Is there a way to make sure that your skin does heal correctly?
It's a great question. Is there a way to push it down a more of a resolution versus a repair? We're going to talk about some of that today. So stay tuned. That's kind of a segue to what we're describing. And that's really kind of the holy grail in regenerative medicine or tissue engineering is trying to repair damaged tissues. And how do we do that with returning function? And when you've got an underlying comorbidity, like age, for example, which is a pathology, how do you combat that? Okay, so we're going to be talking about that. And this is a perfect opportunity for me to pitch a different lecture that's this Friday. So this Flagstaff Festival of Science, you guys know anything about this? Have you heard about it? Oh. Well, it's really cool if I was to show it to you. But now you can see it. Okay. So these are NAU's component of the Flagstaff Festival of Science. The Flagstaff Festival of Science is the longest continuous running science festival in the world that's free. So all of those disclaimers have to be bolted on. Okay. There are some other festivals of science, I think, that have lasted for a longer period of time. Many of them you have to pay for it, whereas this festival you can just show up and it's free. So these are the lectures that NAU faculty are providing. And so I'm providing a lecture this Friday, and you guys are welcome to come to that. It is free. Hang on. Duplicate. Just happened. And it's 6 to 8:30 on Friday. This Friday. Cost is free. It's at the Coconino Center for the Arts, and my talk is called Growing Body Parts. So I'm going to kick off the evening. These are what we call side talks, and the side talks are like TED-style talks, and they're 18 minutes or less, and there's no questions from the audience. It's just more of a very general presentation. I'm going to be talking about regenerative medicine. I'm going to be talking about growing tissues, not necessarily growing body parts, but growing tissues. Okay, so they took some liberative poetic license on the title, but that's okay. So that's this Friday. Do you know where Coconino Center of the Arts is? Okay, so it's north of town, kind of going towards Snowball, but not quite as far as Snowball. There's you would go north on Fort Valley Road, like on the direction of Snowball. There's like the big train that's on the side that's just sitting there, like an old, it's near that. But you can Google it, Coconino Center for the Arts, right? Okay. So we're going to be talking a little bit on Friday evening about the question that just came from the back, and that is, are there things that we can do to stimulate more of a wound resolution versus a wound repair response? And I'll be talking about some of the state-of-the-art stuff that we're doing in the field of regenerative medicine. So that's going to be probably about 6 o'clock. There's an art exhibit. I think there's an art exhibit going on. There'll be like 1 or 2 talks and then a break with beer and wine for purchase, and then you can look at the art exhibit, and they'll call back the audience for the second 2 talks. So the only thing you have to pay for is maybe an Uber ride and then beer and wine, right? Yeah.
So are you presenting right at 6 o'clock?
It sounds like it.
Okay.
Yeah, I'm the first one up, so. yeah, maybe if you got, it might be nice to maybe see the first 2 talks, and then if you need to leave, you can leave during the break, and it won't be as, you know, as obvious. All right, so hold that question for Friday night, but we're going to talk a little bit about it tonight, or today, this afternoon. And what I want to set the stage for is this chart right here that talks about a cell receiving injury, because we see injury happening on a daily basis. Right? Our cells get injured every day. And a lot of times they respond positively and they repair on their own. Sometimes if the damage is so extensive, you might actually see the tissue go through what's called this healing response. And you can see that we've got this healing response and we do not return function, so we get this scar that forms. If it's chronic, like we talked about last week, we might get excessive scarring throughout the tissue. But over here, we've got this category known as regeneration, where there are certain tissues in the body where you can eliminate a vast majority of that tissue, and it has the capability to regenerate over a period of time and compensate for the loss of tissue and restore function. And the liver and the kidney are extremely regenerative tissues. And the skin would be considered in that category when we're young. But at about the age of 10 to 12 is when those reparative mechanisms in the skin start to change. They become a lot more adult-like. They age, they move away from neonatal healing or young pediatric healing, and they move more towards adult type of healing, which is more scar prevalence. So many of you probably have seen this, just anecdotally with your own wounds. You fell off your bike when you were 5, and you swear it was like Evel Knievel style, and you're surprised that you lived. And you look down at your knee, and it's like you can't even find a scar. But like the paper cut you have on the back of your hand from last semester looks really gnarly, right? You're like, what is going on here? So as we age, our tissues repair and heal very differently. Genes get turned off, other ones get turned on, okay? If you look in the literature, scarless wound healing is very well characterized in utero, in the embryo. In fact, there are neurosurgeons that will go in and fix spina bifida patients in utero, and the infant is born, and postnatally there's very little scar along the midline of the back where they went in and repaired the spine. And a lot of the genes that are turned on in embryonic wound healing immediately shut off when you're born because of the switch in hypoxia levels. So the embryo is actually a very hypoxic environment, and that actually triggers certain gene expressions to promote excessive growth, which makes sense. You get a whole organism from one cell in 9 months. And as soon as that baby takes its first breath, a lot of those genes shut off. One is called HIF1 alpha, hypoxia-inducible factor alpha. That shuts off the moment the baby starts screaming, okay? And it's just because of the switch off in oxygen levels, that gene shuts off. And we don't express much of it anymore as adults. So a lot of these kinds of changes happen, and there's not much we can do about it, okay? But there are certain things that we can do. Because all of us would love to see complete regeneration that happens. Like in you and I, every 6 to 8 weeks, our gut and our skin turn over. And we have a completely new organ every 6 to 8 weeks. Now, as we age, obviously that skin turnover, it loses certain components to it. Actually, one of the things that it loses is elastin. And that's why the skin, as we age, gets less elastomeric, okay, less stretchy. It sags, right? It doesn't snap back to where it was because the gene for elastin shuts off at about the age of 12, before you hit adolescence. Not when you're born with hypoxia switching, but right about pre-adolescence or pre-puberty is when the elastin gene goes dormant. So a lot of these things, clinically, we understand, and we can try to combat some of these aging processes in the skin. But what I really want to be able to characterize for today's lecture is this big difference that was described as being, resolution or regeneration here on the left and more of a repair or a healing response on the right. And that's how you'll see it on the exam in 2 weeks. You'll see these terms of regeneration and resolution together, and then repair and healing together. And repair and healing has some sort of fibrous scar associated with it. All right, let's check out this question. Go ahead and answer this question. The role of the fibroblast during the reconstructive phase of wound healing by second intention. What does it do? Does it do A, does it generate new capillaries for the vascular and epithelial cells? Does it do B, does it establish connections between neighboring cells to contract their fibers? Does it do C, does it synthesize and secrete collagen and the connective tissue proteins? Does it do D, provide enzymes that debride the wound of dead cells? That word just means to get rid of the dead cells, debriding a wound. Or two of the above. What do you guys think? How many of you think A? B? C? Okay, seems like it. D? Or E? Couple for E. Okay? So I would go with definitely C is a correct answer, but I would say that B is also happening. So the most correct answer would be E, two of the above, okay, or two of these. So it does help to reestablish the connections between the neighboring cells and contracts that wound, right? That's that first graph that we looked at with wound contraction, right? Those fibroblasts move in to assist with that. So just an example of how these test questions might be, many of you would have picked C and you would have been correct, but there was another correct answer, so make sure you're thinking about all the answers, not just the one that you think it is, okay? So when we look at wound healing, and we look at resolution or repair versus healing or fibrotic scarring, one of the big decision factors in how well the tissue is going to heal is if you see damage to the extracellular matrix, okay? So this is a cartoon diagram that explains a whole body of literature about if you took a liver and you pull the cells out of the liver, okay? You pull the cells out of the liver, you could repopulate that liver matrix with new hepatocytes, and if those hepatocytes take, you're going to have complete restoration of liver function. Okay, and that's been happening in the liver world for a long time, which would be pretty cool. So the analogy would be, you've got access to cadaveric livers, people that donate their body to science or medicine after they're done with it, okay? Could you take that liver from that donor, decellularize it, infuse it with a new population of hepatocytes from the recipient patient who had a liver that was failing, and then could you transplant essentially a replacement liver that had their own cells into it? Okay. Theoretically, yes, you could do that. And so there's a colleague of mine, her name is Doris Taylor. She's doing this actually with the heart. Okay. And if we have time today, I'm going to show you a video of her on Nova. Just got to find the Facebook. So if you go to Facebook and you search for Doris Taylor, N-O-V-A, Nova, PBS Nova, you'll see a little interview of her doing exactly that with hearts. It's pretty cool. Okay. I'll try to find the link at the break and maybe show it to you, or post the link when I find it on the VB Learn site. But the reason that this is even possible, and next week the digital me will talk to you about immunity, right, on the YouTube lecture. You're going to see about tissue rejection, and you're going to see why this can work. If it's your own cells, you don't reject it. But the matrix that's left behind is the architecture that gives rise to a lot of the functionality of the tissue. And so this slide is showing, if you take this normal hepatic lobule up here, and you blow it up at higher mag, and you see this is the portal triad, okay, which is just normal architecture we would expect. And you have damage to the liver where you lose the cells, but then you allow the cells to come back, or you eliminate the cells completely, like in the case of what Doris Taylor is doing with hearts, and you repopulate the matrix with new cells, you restore complete functionality. Now, if you have injury to the liver and you do damage to the matrix in the cells, but the architecture, the roadways, the scaffolding that the cells live in is disrupted, when you allow these cells to proliferate again and come back, you have a disrupted matrix that grows in. It's like the cells, as we get older, they know what to do from a cell standpoint, but they don't know how to reconstruct the house that they live in. So as long as you can deliver the architecture that's appropriate, or you don't lose the architecture in a damaged situation, you potentially could have complete restoration and function, whereas over here, when you have damage to the cells and the matrix, you actually lose functionality, because now the cells that have to move in are cells that lay down new matrix, not just cells that actually perform the hepatocyte function, or the function of that tissue. Does that make sense? So, this is a very key finding that has just kind of revolutionized the way we think about healing. It's given us all sorts of new avenues to pursue as scientists and as clinicians, where we're really trying to preserve tissue architecture. And it's actually set the tone for a lot of the research that I do in my lab. So when we think about how these cells move in and they promote healing, we've got to talk about some older topics that you guys have already covered, right, in previous classes. But we look at the cell cycle. These cells that move in are going to go through this cell cycle because they're going to be kicked into a mitotic phase. They're going to go through replication because they need to make more of them to populate the damaged tissue. So we are reminded of our cell cycle landmarks, and we're going to come back to some of these cell cycle landmarks when we look at the cancer lecture. But just remember and understand that if you think back to, we've got gap 1, which is sort of the gap in between the division and the synthesis phase, and we have gap 2, which is between synthesis and mitosis. These cells rapidly go in a wound environment into a mitotic phase and dividing, making more cells to populate the depleted cells that have been damaged. The other thing that's happening is these cells are talking and communicating. Okay? These cells talk and communicate via 3 different mechanisms. Again, these are basic bioprinciples that many of you have already had. We've got autocrine signaling, we have paracrine signaling, and then we have endocrine signaling, which utilizes flow through the bloodstream. So if a cell is in a mitotic phase of dividing, or if a macrophage is moving into a tissue and is activated, the autocrine signal means that the cell releases some signal that it binds to itself and causes itself to do something. Autocrine, self-signaling. Okay? So these macrophages could be releasing certain types of growth factors that cause the macrophage itself to upregulate its metabolism. Or a fibroblast could be manufacturing a growth factor that causes itself, the fibroblast that made it, to stimulate a mitotic or a migratory behavior. That would be autocrine, self-signaling. Paracrine is when the cell, like the macrophage, releases a substance that causes the fibroblast to do something. The macrophage says, hey, there's damaged tissue, I'm going to stimulate a mitotic signal to this fibroblast that's nearby that's still alive and say, get into gear and start replicating because I need more of you. That would be paracrine, from one cell to another. So you could label this example as macrophage to fibroblast. And then endocrine signaling. Endocrine signaling is where the cell releases a substance, it moves into the bloodstream, it actually goes downstream and it binds to some distant receptor on a distant cell, maybe causing it to do something. Might cause it to replicate, it might cause it to move or migrate, okay? And the endocrine signal isn't as operational in wound healing, per se. The example where it would be involved in wound healing is overall general metabolism is upregulated at the level of the thyroid when we're in a reparative process, okay? So if you've had major surgery, if you've had major trauma, you know that a lot of times you're just exhausted for weeks afterwards, where your body is working hard to repair its tissues, okay? And that is being triggered through a global metabolic increase for the body to repair. Same thing happens, I mean, you've seen the studies, you guys have all experienced it as teenagers, the amount of time that teenagers sleep, right? Because they're growing like crazy. And so metabolism is at an all-time high, and they're trying hard, their body is trying hard to conserve all that energy for regeneration or repair, or just generation of new tissues. So that happens in my house. It's just amazing. I had little ones that used to wake up early with me, and now I can't get them up before noon. You know, but they're in that phase of generation of new tissues, which is aggressive. Okay, and the next one, the extracellular matrix. There's all sorts of unique interactions that happen between the cell and the extracellular matrix, right? So the analogy that I like to use is this is like kids on a jungle gym. Okay, you guys remember the old school jungle gym? I think they're outlawed because they're dangerous or whatever. But they look like a dome and they're made of metal and kids crawl on them, right? And like in the old days, nobody wore helmets. You know, there wasn't any ground up tires below. It was just like dirt, you know, made of rocks. You know, so if you don't fall, you'll hurt yourself. So you just like hung on for dear life. So cells like to hang on to substrates. They have to connect to something. And they attach to those substrates using these integrin molecules, like what we saw when we talked about leukocyte activation, margination, right? Rolling and tethering, or adhesion, and then diabetes. The integrins played a key role in that tethering, or that adhesion, when it finally stuck. Do you guys remember that? So we see these integrins right here. So this is epithelium, here's our basement membrane, and then here is the extracellular matrix. These are fibroblasts, these little spindle-looking, kind of fat in the middle, thin on either side, spindle-looking cells. Here's a blood vessel, and we've got a blow-up diagram here of this basement membrane, and here we've got a blow-up diagram of the cell that looks like it's just floating, but if you look very carefully, there's actually a matrix behind it, like a web. And that cell isn't just floating in thin air. It is attached and firmly embedded in this matrix. That's where it lives. Kind of like these kids on the jungle gym. If you zoom in, you can see here's the fibroblast, here's the nucleus, little purple dot, here's the purple dot, and you can see these integrins actually have it connected to these adhesive glycoproteins that are connected to these different types of collagen extracellular matrix proteins, or proteoglycans. Over here in this basement membrane, you see laminin. Laminin is like a cross-like structure. You see, again, proteoglycans, which are these kind of yellow bottle brush-looking structures. And then you actually see the collagen, which is this double-stranded purple molecule. So these cells like to attach. And so this is back to that liver example. If you disrupt this matrix architecture that they normally live in, they've got nothing to grow back into. And so they have to make the new matrix before, and then it's back to the drywall example. They lay down new matrix, but they're 20 years older than when the matrix was first made. That 20-year-older matrix looks different. They kind of forgot how to make it the first time, okay? And I'll tell you what, the biggest example is there are many different types of collagen. So you see these collagen triple helices? There's like 20-some different types of collagen. And the more youthful, juvenile collagen stops being made as we get older, okay? So we make collagen's not collagen. Some of you are like, well, my mom thinks collagen's great. Okay, we'll tell her not all collagen is the same. In fact, young collagen, youthful collagen, you no longer make as an adult. Okay, it's the juvenile collagen that actually made your skin initially the way it is. And so as we age and you have to lay down new collagen, you're laying down adult collagen, which is a different type of collagen, and that's why it feels different, it looks different. Okay? All right, so that's the matrix. Signaling pathways. There are all sorts of signaling pathways that happen inside the cell that tell these cells that are going through a repair process to do something. So here we can see, this is at the extracellular matrix level out here. This is the collagen, the triple-stranded collagen. You can see the integrin molecule in higher magnification as an alpha subunit and a beta subunit. And the alpha and the beta side of the integrin, which is a transmembrane protein, it's stuck through in the membrane. This is the cell down here with the nucleus in the middle. It is physically attached to the collagen and fibronectin outside the cell. It is also physically attached to the actin cytoskeleton inside the cell. So you can see with these FACs, these focal adhesion complexes, that's where the alpha and the beta subunit coalesce, and then they attach to the cytoskeleton, the structure, the trusses that make up the inside of the cell, which is physically attached to the nucleus. So you can see that outside signals can cause the nucleus to do something. So for example, if there's no more matrix, it gets degraded or damaged, it triggers the nucleus, I'm not attached to enough matrix, make more matrix. And now the cell spits out new matrix. Yes, it's new, but it's different than the original. And so as it lays down new matrix, that's older matrix than when it was originally made, that extracellular matrix environment that the cell lives in is a little bit different than what it was before. Okay? Likewise, the inside of the cell can signal to do things that cause the outside of the cell to do something. Saying, let go of those attachments because we need to migrate that way. Well, you can't migrate that way if you are still stuck right here. So the cell will upregulate integrin expression on this side of the cell. It'll downregulate integration on this side of the cell, and now the cell actually will move that direction, and that's migration. Pretty cool, huh? So the outside of the cell talks to the inside of the inside of the cell influences what happens outside of the cell. All right, another big important feature in wound healing, and these are all the mechanisms that are in play, right? All the take-home messages from each of these slides are specific things that are necessary during a wound healing response, no matter what the tissue is. I like to use skin as an example. It's the one that we use a lot in my lab. I think it's pretty easy to visualize because people can see it, but the same kind of processes, bless you, are happening in like liver tissue as it heals, or cardiac myocardium as it attempts to heal, although it doesn't heal very well. So angiogenesis, up top is a diagram that shows from the left side of the screen to the right side of the screen, if you have damaged tissue and you need to repair it, or you need to heal it, or you need to resolve it, you actually need to increase perfusion to that tissue. You have to upregulate blood flow. And the reason for that is metabolism in that area is going to go up, so you need more energy in the form of ATP. In order for ATP to be cranked out at high levels, you need cellular respiration to go up, so you need more oxygen flow. And you need to deliver nutrition, like in the form of glucose, or supplementation as far as cofactors and enzymes. So blood flow brings in nutrition and oxygen, and it also allows for the waste products of metabolism to leave. So blood perfusion brings in nutrition and it eliminates waste products. So angiogenesis is really, really important in wound healing, and we're going to see some examples today, and you probably know about these examples. There are certain pathologies, underlying pathologies in patients where their wounds don't heal very well, and they don't have an angiogenic process that moves in to help promote healing. The example that I'll foreshadow to, and we'll talk about it later, are diabetic foot ulcers. So patients that wrestle with end-stage unmanaged diabetes have a lot of poor perfusion to the distal extremities, like the feet. And so if they get a wound on the bottom of the foot, it's very difficult for them to revascularize it because, and we'll talk about that more when we talk about diabetes, but the blood vessels themselves have lesions in them because of the high sugar content. And as the lesions impede blood flow to the distal extremities, now the tissue that's damaged doesn't get the nutrition that it needs in order to promote healing. So this is a key component to developing a new mature vasculature that allows for the promotion of healing in these tissues. This also happens to be the way that cancer hijacks the system, okay? So we're going to see, different topic when we look at cancer in a couple of weeks, like at the end of October. Cancer tries to grow outside of the normal cell cycles, and one of the ways that it does that is by increasing its vascularization to the lesion, and then it allows it to grow out of control, okay? But this is a key component for normal healing, and then cancer hijacks the normal processes, and it mutates things, and it does something very, very different. Question here and then in the back.
Is this the basis for anastomosis?
The basis for surgical anastomosis?
Not surgical, just like how you acquire anastomosis throughout life.
During development or during growth? Yeah. So the question is anastomosis. Anastomosis is just where one vessel branches into another two, or one vessel dives into another vessel, and like a Y point or a T point. And so this is how that sprouting of the vasculature actually takes place. It's through an angiogenic process. And the other thing that's interesting is there's a lot of redundant circulation in the body that's built around angiogenesis, okay, or another term that's known as neovascularization. And that means, so the large blood vessels that come down, like, so for example, the aorta is the main vessel that comes off the heart, it turns and then it comes down the chest, and then it dives and bifurcates or branches into the right and left femorals. There are a lot of side branches off the aorta that perfuse the spine, that perfuse the spine itself. And if any one of those vessels gets blocked, there's another vessel nearby that can perfuse the same tissue. And you have what's called a lot of redundant or collateral circulation as a result of angiogenesis. Question in the back here.
Yeah, so for diabetic patients who like lose toes and stuff and get injuries, how long would you say it takes to develop something like that? It just depends on their body.
Yeah, so the question is, in diabetic patients that lose digits like toes or feet or limbs, how long does it take? And then you answered your own question, which kind of depends on that particular patient and how aggressive the disease is. So what's a common scenario is the patient will have what's called limb claudication. So they have pain in their feet when they walk. And a lot of times that limb claudication might be intermittent. It's fine when they're resting or sitting, watching TV, but as soon as they get up to go to the bathroom or the kitchen or the bedroom, it hurts when they walk. Then usually it progresses to what's called parathesis, or the numbing or the pinprick feeling, you know, when your foot goes to sleep. And that's usually the first sign that the nerve's dying. And nerves are very sensitive to oxygen levels. And so if it's not getting enough oxygen, it'll send a relay signal back to the central nervous system saying, you need to do something about this. And that's why you feel that nerve being irritated. And that's that foot asleep feeling. So when their foot's asleep, that's usually the next sign that you've got. And a lot of times that is chronic. Like they have trouble falling asleep in bed at night because their feet are numb and it's bothersome, right? You guys all had your foot go to sleep, right? Now imagine trying to go to bed while it's asleep. You know, I'm always like doing one of these. I don't know why I feel like that's going to help, but you can't do them when you're sleeping, right? So they have trouble sleeping. Then they usually get a lesion or the toe gets compromised because that's the most distal extremity. They might have to amputate in order to prevent an infection from spreading. So they'll go toe, then they'll go foot, then they'll go lower limb, and a lot of times they try to keep the knee, so it's below the knee. So BTK is what that's called, a BTK amputation. Why? If they can save the knee, it's much easier to fit them for a prosthetic if they've got a lot of the knee joint itself already intact. And as much of the lower leg as possible that you can actually strap something to it and fasten a prosthetic to. Above the knee amputations are usually people that are in wheelchairs. Okay? And that's the progression. So if we can develop therapies to treat these distal wounds, that's the progress of the disease that we'll prevent.
Yeah, I was just going to say, because I saw this patient when I was shadowing at the hospital, and she was missing like a large chunk of both her heels and like several digits on her toes.
Yep.
So I was just curious, like how long it would take or something like that.
Yeah, it just depends on like how progressive the disease is going in that individual. Sometimes it's months, other times it's years, right? It just sort of depends. Okay, so I asked the question, I posed the question about healing by first intention and healing by second intention. So tell me, what is the healing by first intention? Who can give me a definition of that? First intention healing. You guys? Very good. Yep. Usually zero trauma, yeah. So a clean, sterile incision that usually isn't due to a traumatic event. So this would be like a surgical incision, okay? And those are wounds that heal usually pretty nicely. You've got a clot that forms in the first 24 hours that's rich in platelets. You get the neutrophils that come in. You can see the underlying vessel flow. You can see this is skin, so this is the epidermis up top, and this is the fatty layer, the hypodermis. And in about a week's time, you've got the dissolution of the clot. You've got macrophages that take over from the neutrophils, they're the second cells. You got an expansion of the capillary network, or the angiogenesis. You get granulation tissue like we saw in the timeline. And then weeks later, you can see that the vessels are angioregressing. They're no longer needed, so they dissipate. You've got nice restoration of the epidermis, restoration of function, okay? You've got minimal scarring. You've got a fibrous union. You lose a lot of the cellular infiltrate, like the macrophages go away. They're not needed anymore. And you usually have a very nice aesthetic outcome, okay? That's healing by first intention. Healing by second intention is very, very similar, but it's usually due to trauma. It's usually due to an accident, okay? Not a nice, clean, aseptic or sterile surgical incision. And so you get a much broader wound margin. Everything happens but more aggressively. Because there's a bigger chunk of tissue that's missing, you actually usually don't see complete restoration of function. You get the filling in of the wound after weeks to months later, but you have much more fibrotic scarring that's there to try to contract that wound and bring it together. Okay? So a lot of you have heard of, well, you could have your scars modified. How would you have a scar modified if you didn't like the way it looked? So if you have a wound that was here, and then it closed, and so now your wound is, let's say it's kind of like this, like we see with this diagram. You can take this resulting scar, and the plastic surgery can create healing by first intention by surgically cutting the margins, pulling that tissue together, right? And eliminating this entire section where you basically have a wound that now looks like that, okay? So that's a surgical revision of an old wound, right? And those are aesthetic surgeries that plastic surgeons do, and they can do them all over the body. And obviously, if you do this when you're younger, you're going to get a better result than if you do it when you're older. But you know, that is something that is in the clinical space that a lot of patients want to understand. How does that work? How does the plastic surgeon make it look better? Well, a lot of times they'll take out that scar tissue and they just convert a second intention wound to a first intention wound and let the body do it all over again. Okay, question?
Why do some scars heal or look differently? Like some look like indents in the skin while others are like bumps out of the skin?
Okay, that's a perfect segue to this next section. So, the appearance of the wound, or the scar, post-wound. Why does it look different? Well, all of us have different biology. Okay, so some individuals heal much more completely and in much better process than others. Some people are very they're very prone to scarring. And some people say, well, I keloid a lot when I heal. What does that mean? That's just a word that means that you produce an excessive amount of collagen in the wound bed. And that collagen isn't contained within the wound bed, so it kind of raises up above the wound bed and actually forms a bed of collagen on top of the epidermis. I'm going to show you pictures of that here in just a minute. But first, let's start out with this guy. So this is like the patient that you see, okay? But this is probably earlier in the process. This is a diabetic foot ulcer, okay, or a pressure ulcer that's forming on the foot of a diabetic patient. And histologically, this is what that tissue looks like as it's attempting to heal. So this is in the granulation tissue phase, and the reason we know that is by the appearance of the tissue down here. So this is the wound margin. This is epithelium right here that's trying to grow down. This is epithelium right here that's trying to grow down. There's no epithelium right here. You see this little thin tissue right here? That's the epidermis or the epithelium, and you can see that it's absent down here at the base of the wound. And this is all granulation tissue with the presence of infiltrated macrophages as well as all these new vascular elements. All these white open spaces are all blood vessels. Okay? So this is the granulation tissue. As this wound was to heal, if we could promote healing in these wounds, like in this patient, we would love to see this. So this would be at some point in the near future, you could see that now that tissue bed has an epithelium that covers the entire surface. The blood vessels are a lot more obvious. Like here's one right here, here's one right here, here's one right here with a red blood cell in the middle. Here's one right here with like a stack of 5 red blood cells in the middle. Here's one right here with a whole bunch of red blood cells in the middle. I'm not going to try to count them. Here's a blood vessel. This is the form or the phase of granulation tissue that's developing as the wound epithelializes. As we move on in the healing, much more pronounced epithelium, right? We've got a nice thick layer of epithelium as it's closed over. So we would put on that particular foot ulcer, if we put a wound vac, or if we debrided the wound and then treat it with antibiotics and put a wound vac on it and a treatment covering, we would hope to get this type of outcome. But what you can start to appreciate, to the question that was asked earlier, is here's the epidermal-dermal interface right here. Here's the epidermis, and this is the stratum corneum, the outermost layer that sloughs off. And you can see that it's a little raised right here. Over here it's a little bit more smooth. So this particular patient would have a little bit of a bump, right, on the surface. If you ran your hands over, that'd be a little bit of a scar. Look at the underlying dermis. So all of this pink is new collagen. And you can see there's collagen over here, there's collagen here, there's a little bit of a gap right here. There's a wave of collagen in this area, there's a gap, there's a wave of collagen in this area, and then there's a wave of collagen in this area. So the collagen isn't completely homogeneous, right? It's patchy. And so that's going to give that remodeled tissue a little bit of a different feel than the native tissue that used to be there. And that's the scar that you're feeling, okay? Now, if it's extremely aggressive, the amount of collagen that gets laid down, then you get a keloid. And this is an example of a patient that is very prone to keloid formation. And so you can see that this raised tissue above, it's not cancer, it's not a lesion, right? It's just new growth or a neoplasia that's forming, like a new growth. It's not cancerous, but it's a new growth that's forming as a result of wound healing, and it didn't stop at the level of that epidermis. It just kind of spilled out beyond those boundaries. What does it look like histologically? All of those arrowheads, or arrows, those black arrows, are pointing to the excessive amounts of collagen that are underneath the skin in the dermis. Okay, so this is keloiding of the skin. You can kind of appreciate this is definitely not smooth across the top, right? You've got all these bumps, all these invaginations, because you're building up more collagen, you're plumping up the tissue beyond what it really used to look like, and that's where that keloid is coming from. Really all it is the fibroblasts are being stimulated to produce more collagen than what's really necessary. They're being overly protective, okay? They're putting out too much collagen. And in this case, from an aesthetic standpoint, too much might be not a good thing. All right, let's pause here, take a break, and we're going to come back and talk about stem cells and how they fit in to what's going on within wound healing and in this story of how the body prepares.